Thank you, Dr. Cohen, Dr. Koster, Dean Reimer. I'm Leah Devlin, and I'm delighted to be back here with all of you again today. I wanted to just drive home the point again about how this event has been developed by our partners, and that's the hallmark of how we work together in public health in North Carolina through partnerships and through collaboration. I'll be moderating today's very exciting session featuring Dr. Tom Frieden, who is joining us from Delhi, where it's already 6:15 p.m. in the evening. We remember when Dr. Frieden was here with us in person at our School of Public Health, and he spoke to hundreds of our students and faculty, and it was incredibly inspiring. In fact, we're still talking about it. So we're really delighted to have him back with us again today. We are privileged to hear his perspective as one of the world's top public health experts in the world on how strong policies can make us safer around the globe. Strong policies not just in the United States, but in other countries, particularly focusing on middle income and low income, low resource countries around the world. We will have time for questions, so please be thinking of how you want to engage with Dr. Frieden and come to the mics quickly after his remarks. Many of you already know Dr. Frieden from his leadership worlds in the nation and around the globe. I first had the opportunity to get to know Dr. Frieden when he was the New York City Health Commissioner, and he and his amazing team worked on so many important public health issues and with such ardor and effectiveness that he actually led to a rapid increase in life expectancy in New York City. Now, those of you who know Dr. Frieden well, particularly from our infectious disease community, know that he has made his mark also in tuberculosis control and also prevention. He has led the investigation of the outbreak of the largest multi-drug resistance efforts in our country, and he also was foundational in establishing the largest tuberculosis control program in the world in India. So he's come full circle this morning. Probably his most visible role for all of us has been as the director of the Centers for Disease Control and Prevention from 2009 to 2017. Because of his work there, Americans, all of us, are safer from antibiotic resistance, foodborne and healthcare-associated infections, heart attacks, strokes, cancer, and exposure to dangerous pathogens, including Dr. Cohen, HIV, and for this morning's purpose, pandemic flu, but many others. Ebola also comes to mind. Dr. Frieden continues to be an ardent advocate for a strong Centers for Disease Control and Prevention. Dr. Frieden is currently the president and CEO of Resolve to Save Lives, a $225 million five-year initiative housed at the globally focused nonprofit Vital Strategies. This effort is funded by Bloomberg Philanthropies, the Gates Foundation, and the Chan Zuckerberg Initiative. The goals of Resolve to Save Lives are twofold. First is to literally save 100 million lives over 5 years by implementing proven solutions to prevent heart disease and stroke, which are the world's leading causes of death. The second aim of Resolve is to prevent the next disease outbreak by catalyzing urgent country action around the world to detect early, respond rapidly and efficiently to an emerging outbreak, either a tried and true pathogen or a new emerging one. If anyone can save 100 million lives, if anyone can build capacity in countries around the world to strengthen their public health system, it is Dr. Tom Frieden. We look forward to his remarks and to the discussion he will have with you. Dr. Frieden, the remote microphone from India is now yours.
Thank you very much, and it's great to be there with you. First, let me ask if you can hear me all right. Yes. Great, and I can hear you. And when I do this, can you see my slides? Yes. Fantastic. Despite a big storm outside and many thousands of miles, I feel like I'm there with you and really do appreciate the chance to share. What I thought I would do is speak pretty quickly about some of the key issues and then open it up for a discussion. And of course, as we are in 2018, we think back 100 years, and I've seen your program. It's very impressive. It reminds me of a retreat I went to with some congressmen years ago, where at the end of the retreat, someone said, everything I wanted to say has already been said, but not by me, so I'm going to say it. And I'm afraid I may be repeating some things that you've already heard by people who are certainly more knowledgeable than I about them, but I'll give you a sense of my take on where we are, just with influenza, but with a variety of health threats. So let me move to the slides now. Let me just verify that the slides are up with you. Yes. Great. And I'll focus on the word policies for a moment. Policy is the royal road to progress. Program tends to get the attention and the funding, but often policies are what drive more rapid health progress. As you all know, the global pandemic from 100 years ago killed probably more than 50 million people worldwide. And look at that graph on the bottom right, this dramatic decline in US life expectancy. So massive global economic disruption, and it killed more people in 24 weeks than HIV killed in 24 years, and more in a year than the Black Death killed in a century. Most of those killed were previously healthy, and around the world, health systems were overwhelmed. Have we learned lessons? Well, in 1918, there were no flu vaccines to prevent infection. There were no antiviral drugs. I think you just saw my invitation to play squash on the screen. Sorry about that. My invitation to, there were no antiviral drugs to treat flu. There were no antibiotics to treat secondary infections. There were no mechanical ventilators or intensive care units. And there were no modern respiratory protection devices to reduce transmission. Now, we have made advances in each one of these 5 areas, but still in each one of them and in others, there are real problems. There is an increased globalization and interconnectedness, so diseases spread a lot faster now than they did a century ago. There are more novel pathogens, on average 1 a year. New vaccines can take months to develop, distribute, and administer, and have limited efficacy. And let me say that I'm delighted that NIH has significant dollars for a universal flu vaccine. It's much needed. However, that is a long way away, and we could probably do a lot of good if we rigorously studied the 4 vaccine types on the market, figured out which worked best, and then use that information to optimize vaccine development. Pandemics will overwhelm even the best healthcare systems, and I recall looking at Singapore dealing with SARS and thinking, wow, if the very administratively efficient, let's say, city-state of Singapore has a problem with this, imagine what would happen if it hits elsewhere. And of course, the greatest moment of terror in the Ebola epidemic was when it almost got out of control in Lagos. It was really just days away from getting control. Most of the world remains unprepared. And if you look at these areas, flu vaccines are still not going to be here on time in most of the scenarios of a pandemic. Antiviral drugs are here, but they have limited impact, and it's hard to get people to use them. Antibiotics to treat secondary infections are very important, but flu can kill from viral infection as well. And the mechanical ventilator challenge is not a small one. When I was at New York City as a health department, and again at CDC, I was quite concerned that ventilators were the lowest common denominator of emergency preparedness. And so the Strategic National Stockpile, in my time at CDC, greatly increased the number of ventilators, and we've looked at what could we do to increase preparedness, because it's not just the machine, but the respiratory therapists, and how do you scale that up in an emergency. A lot more now about transmission of flu. New studies show, for example, that source control, covering the mouth of the person who's sick, makes a really big difference. And the tradition in Asia of wearing a mask when you're sick has a lot to recommend it. As Leah mentioned, I'm currently honored to lead a global initiative called Resolve to Save Lives. Our goals are to prevent 100 million deaths from cardiovascular disease and to make the world safer from epidemics. We're delighted to have the donors that Leah mentioned, Bloomberg Philanthropies, the Chan Zuckerberg Initiative, and the Bill and Melinda Gates Foundation. We have core organizations that we support around the world, financially and technically, to establish a partnership on each of these two areas. And I won't talk much about the cardiovascular initiative since we're focusing on flu, although of course, as you know, influenza increases heart attacks in an important way. But we have a simple formula that 50/30 plus 0 equals 100. And the way that works is that if we increase global control of blood pressure from 14 to 50%, reduce intake of sodium by 30%, and eliminate artificial trans fat, we will get to 100 million lives saved in about 30 years. And the elimination of artificial trans fat would be the first global elimination of a non-communicable disease. The World Health Organization has now called for it, and I look forward to seeing real progress on that. In the making the world safer from epidemic space, we're focusing on core systems, the core four of tracking systems or surveillance systems, trained epidemiologists or disease detectives, strong laboratory networks, and rapid response teams that can stop outbreaks quickly. A disease outbreak anywhere is a health threat anywhere. Disease can travel across the world in just 4 to 6 hours. And there are lots of reasons why epidemics are missed and how they're found. For example, we know that it always, or just about always, begins with an alert clinician. But the alert clinician needs to have access to a good laboratory network, needs to have an ongoing relationship with the local health department. There needs to be a tracking system that can tell if something unusual is happening. There need to be trained epidemiologists who can analyze that, looking at the labs from the reported patients. And there needs to be political courage to say, even when it's not definite, there may be an outbreak here and we're going to take appropriate action. And this always comes up. There's always a voice that says, oh, but maybe it's not real. Oh, but we're going to have economic losses. Oh, but tourism will be down. So all of these things are necessary for epidemics to be found or reasons why they may be missed. The World Health Organization has international health regulations. These were updated after the SARS epidemic. And fundamentally, they talk about preventing avoidable outbreaks, detecting threats early, and responding rapidly and effectively. I'm extremely excited about the Joint External Evaluation process. This is the first time ever there's been a global accountability framework for epidemic preparedness. And it tells you very simply whether countries are ready. And what we know is that we're doing a pretty good job at assessment. By the end of this year, more than 100 countries will have gone through joint external evaluation. And yet, very few have gotten the money to close the gaps that are found. And these gaps are life-threatening gaps. So we've been trying to see if we can leverage resources to fix gaps in those critical areas of trained epidemiologists, laboratory networks, rapid response capacities, surveillance systems. This is some of the results of the joint external evaluation process. You can see that in Africa, there's not a single country yet that is documented as being ready. Some have work to do, some are not ready, and the ones that are blank here have not even asked for an assessment yet. Resolve will help to assess and track preparedness to address critical gaps. Most countries have the intention and determination to prepare for epidemics, but they're not adequately prepared yet. And so we'll focus on these 4 areas. We've already begun work, particularly in Nigeria, where there's a really good new public health institute and director. They're responding effectively to a very large outbreak now of Lassa fever, as well as multiple other outbreaks. But what we see there is what we see in many places. The better programs get, the more outbreaks they find. The more outbreaks they find, the more busy they are dealing with outbreaks. The more busy they are dealing with outbreaks, the less able they are to implement the systems that will prevent those outbreaks in the first place, whether it's vaccination or identification of risk factors or mitigation of risks from food and water. What we hope is that strengthening all of these systems will not only strengthen the response to unusual emergencies, but perhaps more importantly, strengthen the response. I'll come back to that in a moment. Epidemic prevention is smart spending. The cost of a pandemic is many times higher than the cost of preventing that pandemic. We estimate that it's about $1 per person per year in low and middle income countries to establish the basic core requirements for disease protection. But that money isn't forthcoming. I'm pleased that the current administration the current Congress, I should say, funded the Global Health Security Program at CDC, even though that program hadn't yet run out of money. So it's very encouraging that Congress put $50 million more in CDC's budget this year. They've been running about $150 to $200 million a year program. It will expire next year. So if since the Congress put $50 million in this year, if they put $100 million in the next year and $150 million the year after, they'll make this program a stable program. As you know, diseases know no borders. And because of that, we won't be safe until other countries are safer. We won't be secure at home until countries are safer abroad. And that essential connection of the world is not going to change. And because of that, it is not only the right thing to do, but in our self-interest to help other countries become better prepared. In Resolve to Save Lives, we have 3 key principles: simplicity, speed, and scale. We're delighted to have great support from our donors, and we're delighted to partner with groups around the US and around the world to promote preparedness in any way we can. I'll just end with one thought. The systems that work most effectively are systems that not only can be scaled up in emergencies, but systems that work well every day. Systems that can identify a problem, respond to it promptly, analyze the situation, and scale up an effective response. Systems like that need to be used every day. They can't be fire alarms that you break the glass when there's an emergency. There's systems like the Vaccines for Children program that could be scaled up. There's systems like disease reporting that can be used effectively. There's systems like electronic death registration, which in a catastrophic event would be enormously important to tracking trends. What we have to do, both in the US and globally, is not only build programs and develop new tools, but better apply current tools to be used every day to improve response. And in that regard, I think this is a crucial lesson in the 1918 pandemic that is as relevant today as it was 100 years ago. Thank you very much.
Thank you, Dr. Frieden. You never fail to inspire and stimulate our thinking on what we all can do to help with this amazing global mission that you have undertaken. Thank you so much. Since you're not here, I just want to note that we have an audience that includes researchers from all over the country. We have practitioners, we have faculty training the future public health workforce, and a few people from the corporate sector here today. So I don't think there's going to be a lot of shyness in this group. So we're queuing for questions, and if you'll say your name, and I know you, Zach, Dr. Moore, but if you'll say your name and where you're from, and you'll succinctly ask a question.
Sure. This is Zach Moore. I'm the state epidemiologist here in North Carolina, and it's to your last point that my question relates, and that's I think many people get frustrated at this cycle of emerging threat, political attention, funding. The threat is addressed theoretically successfully, and then the funding goes away and it's forgotten, and it doesn't lead to any lasting increase in capacity for the next threat in many cases. And so I just wonder how, if you have any other thoughts on how we shift that narrative and towards building the fundamental capacity and sort of recognizing that what enables us to deal with this threat is in many ways the same as what would enable us to deal with future threats.
It's a great question. I don't have a perfect answer, but part of the answer is going to have to be outside of the government to encourage the government to do the right thing. When I was appointed Assistant Commissioner of Health in New York City and Director of the Tuberculosis Control Program, I got some advice from James Q. Wilson, the leading scholars of government. And what he said was, you won't succeed and your programs won't be sustained unless you have groups outside of the government pushing for you to do the things that need to be done. And that's a very important lesson. I also learned a lot from Senator Inouye, who was then chairman of the Appropriations Committee in the Senate, who, when I asked this question, said to me, don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money. So I think a combination of those approaches is important. We also have to get better at communication, making clear that public health is about protecting everyone. There's a misconception in many quarters about what public health is about. A lot of things that public health does, people don't realize public health is doing. We have to try to make that more visible. Easier said than done, but every opportunity we have to do that, whether it's a flu season or an outbreak or a data release, is an opportunity to build momentum, to build support. When I was at the City Health Department and at CDC, we released a monthly report, did a telebriefing, got a lot of coverage on a variety of health issues. This is a cacophony of voices these days, so to be effective with it is not easy, but it's very important. Back over to you.
Yes, thank you. Those of us in the practice community join you in saying that we feel like the public health system is a quiet miracle. So we'll go to our next questioner.
Yes, hi. Hi, my name is Priscilla Wald. I teach English at Duke. Thank you for that amazing talk and for the amazing work you're doing. I'm really inspired. Also, that's the best Skype talk I've ever heard. That's not an easy medium. And what I want to ask you about, and I think I hear it in what you're saying, is how your organization thinks about and defines health. Because I'm thinking here of the work of Paul Farmer and also of Margaret Cho's call to return to Alma Ata and think of health as a state of well-being, a human right, and in that context, the need to address global poverty broadly as the single vector, most important vector that turns an outbreak into a pandemic. So is that something that your organization thinks about? I realize you can't do everything, and you're doing amazing things.
What results in the health status of a population really is very broad societal factors. From what's called the social determinants of health, poverty, education, housing. This is the substrate for health. Years back, I was principal for a day in a New York City school. It's a nice thing that was done. And I was with a group of 8th grade in the inner city. And I asked, what's the single most important thing you can do to live a long and healthy life? And I was looking for something like, don't get HIV, or don't smoke, don't do drugs. And one 8th grade young woman raised her hand and gave me a better answer than I had in my mind, which was graduate from college. And she was absolutely right. This is the strongest predictor of health, this level of education. Not the only, but the strongest. So that bottom level is the social determinants of health. Above that are things that change the default value. Clean water, clean air. Things that make it so if you go about your business, you'll remain healthy. You don't have to deal with cigarette smoke in your workplace, or as we do here in Delhi, salmonella in the water or food. The next level up are light touch clinical interventions, things like immunization, colonoscopy, or one-time counseling for tobacco use or alcohol use. These are interventions that make a big difference, and they can be done once or every few years. At a level above that are the clinical interventions that require long-term, consistent functioning of the healthcare system, like control of blood pressure, where globally we're only at 14%. And at the top of that kind of pyramid of impact is counseling, education, and one-on-one activities. These are 5 areas where we can affect health. And to maximally improve health, we want to work on all 5 of those areas. But realistically, our unique perspective in public health is, one, the ability to bear witness, to talk about where there are horrific inequities in health. Martin Luther King Jr. said, of all injustice, injustice in healthcare, inequality in healthcare is the most shocking. And if you step back and think about it, it really is. Someone lives or dies depends in many cases on whether they can get competent care. At the height of the Ebola epidemic, one of our very beloved drivers in Sierra Leone was waiting for our team in a parking lot. He began having seizures and bleeding, and he died. And the assumption was he must have had Ebola, so he couldn't be safely resuscitated in that context there. But when the situation was investigated, it turned out he had hypertension, which was untreated, and he had a stroke because of untreated hypertension. Globally, there are 1.4 billion people with high blood pressure, and 1.2 billion don't have it under control. And from that 1.2 billion people arise 10 million people a year who die from hypertension, more than all infectious diseases combined. Within the public health space, we can bear witness to inequalities and the need for improvement in the social determinants of health. But we can also implement specific programs that will make a difference and address some of those inequalities. Those specific programs include things like hypertension control, things to prevent epidemics, areas where we can make a big difference through reducing tobacco use or vaccinating against killer diseases. Our approach then is to work in the general, in bearing witness, advocating, and trying to take where we can actions that will change the structure of inequality, whether that's clean water or access to family planning, which will reduce poverty in the next generation, or our specific programs like vaccination and hypertension treatment, which will make a huge difference in people's lives. I'll end with a story. When I ran a tuberculosis program in New York City, we had a terrible social situation. We had mass homelessness. We had people living in shelters. We had very poor infection control in hospitals, and multi-drug resistant tuberculosis spreading around the city. And there was one theme of thought that said, you know, this is not going to get better until we fix the housing crisis in Yale, our ability to do infection control in hospitals generally, and a variety of other things. And there was a sub-theme of thought that said, and even if we could control it, we probably shouldn't, because with tuberculosis, we can fix these other things. I didn't agree with that perspective. I wanted, of course, homelessness to be solved. But here we are 25 years later, and we've still got a big homelessness problem. But we don't have any big tuberculosis problem. And that's not just an individual issue. One of the big challenges at that time was that there was a small number of patients, 1-2%, who just wouldn't take their medications, no matter how sensitively they were offered. And they were very visible to the clinicians because they came back to hospitals, one of them 32 times infectious. And the hospital said, what can the health department do if they can't even deal with these individuals? So we established a secure unit to care for people with tuberculosis in the hospital until they were cured. And Boston had been doing this for years. So we went up to Boston to see their program and learn from it. And I kind of said, you know, these people have so many problems in addition to tuberculosis. Are you doing any good? And I'll never forget what the nurse said to me. She said, they come here, they've got tuberculosis, many of them are HIV positive, they're homeless, they're mentally ill, and they're drug addicted. They leave here, they're still drug addicted, mentally ill, we may or may not have found them housing, they may or may not be on treatment for their HIV, but they don't have tuberculosis, and that's not a small thing. It's a big thing for them in their lives. We've done them a lot of good. And I think more broadly, that's an important perspective in public health. Thanks.
Thank you.
Thank you, Dr. Frieden. We have talked about disparities in dealing with epidemics and reaching those who are outside the system or not participating in all of the efforts to contain an outbreak. So thank you for bringing that home again. Dr. Koster?
Thank you, Leah. India's Association of Science Centers is renowned for its attention to public health issues, much more than the rest of the world, in my knowledge. And this Going Viral Symposium, as you may know, is accompanied by both an exhibition that opens next month at the National Museum of Natural History in the Smithsonian, and also a roving pop-up exhibit. And we're bringing it to a public front tomorrow at the North Carolina Museum of Natural Sciences. I would invite you, since you have such global knowledge, to recommend, if I may, to the more sort of Euro-North American museum and science center field. You know, what we should be doing more of in the public health area. It's not a subject that comes up very often, and it obviously is lacking in that regard. You know, we like to say in this country that more people visit museums than go to professional sports live each year, but we're not doing a very good job, I will criticize, in terms of being relevant to the issues that are this fundamental. So if you had the bully pulpit, if you were a keynote at the American Association of Museums meeting, what would you say?
First, it's a great exhibit. By all means, get whatever part of it you can. Second, the Centers for Disease Control and Prevention has a museum. It's affiliated with the Smithsonian. They have great exhibits. They can be rotating. They probably need some help with funding because Congress doesn't want to fund museums. But they're wonderful exhibits, very important, very powerful, very interesting. I would say even surprisingly interesting. I shouldn't probably tell the story, but I was walking past the museum one day, ushering Mayor Bloomberg into CDC, and we walked through the museum, past the museum, and I said, this is this. Not quite rolled his eyes, but kind of shrugged. And I said, you know, it's actually much more interesting than you'd think. And he said, it would have to be.
Thank you, Dr. Friedman. Dr. Koster.
It is actually quite interesting. There are some photographic exhibits that are very powerful and tell stories. And ultimately, what we want to do, whether it's about health or global issues generally, is tell stories. And there was an exhibit there, I'm not even sure if it's a CDC exhibit or a broader one, of where children sleep around the world. Photographic as well as demonstrations. And it's very, very powerful. And if you speak to the folks there, they're important. Plus, you can look inwardly at your local community. At the Museum of Natural History, we've done quite a few very powerful programs on health, both lecture series as well as exhibits. And there in North Carolina, you have a really good public health program. You can think about what you can do together. You can also, museums have been terrific at doing outreach to schools. There's important things you can do there as well. So those are a few ideas.
Thank you, Dr. Frieden. And we do work closely with our Museum of Natural Sciences here in North Carolina. And we're going to take one more question. We're going to let Dean Reimer, the Dean of our School of Public Health, wrap us up.
Dr. Frieden, thank you so much, and thank you for your global leadership. I was proud to be able to hear you a few weeks ago when you spoke to the Association of Schools and Programs of Public Health, and you did a great job, and you did a great job this morning. I'm really struck, and I agree with your comments about speed, simplicity, and scale. And I wondered if you would just comment, there are a number of students here and faculty and others, what are the kinds of skills that maybe we aren't teaching so well in schools of public health right now that would help to achieve speed, simplicity, and scale?
Thank you, and thank you, Dean, for all the great work you do. It's great to hear your voice again and interact with you. I would start with simplicity. There's that old saying, I didn't have time to write you a short letter, so I wrote you a long letter.
Yeah.
One of the things that we're doing in hypertension treatment is simplifying. Not dumbing down, but simplifying. If you look at Kaiser Permanente, the top healthcare system in the US, their results are better than any other place in the US, and they use a very simple protocol. Start with half a pill, double it to 1 pill, double it to 2 pills. There's no way to get speed and scale without simplicity. So you have to start with that. And that means that the students that we train should be able to integrate information. As I said at that conference, I've often thought if I were designing the final exam for a public health program, it would be, you've got 4 hours on the internet, here's the problem, give me a one-pager about what to do about it. And I thought of that because it actually happened. I was in New York City, and suddenly, as commissioner, I forget why, but there was an opportunity to establish a program in our schools to expand dental sealants. But we had 4 hours to develop a one-pager that would go to the budget office and the mayor and would be decided on. And a very good special assistant who knew absolutely nothing about dental sealants at time 0, by the end of hour 4, had produced a terrific one-pager that resulted in a big dental sealant program in New York City. And that kind of clarity and simplicity can lead to scale. On the speed issue, I think it's important to be relentless, especially in the public sector and the academic sector, to recognize that every day, every week, every month that goes by, and we're not implementing programs, people are dying. Bill Foege says that public health is best when we see and we help others see the faces and the lives behind the numbers. And for that, I think all of you in the audience are so important, locally, nationally, and globally, to help us see the numbers of people who are becoming ill, disabled, dying, or at risk for dying because we're not acting today to reduce the risks. So thank you all very much for what you do, and best wishes for the rest of the conference.
Thank you so much.
Thank you, Dr. Frieden, for your marvelous presentation and for putting us at the end of your day, which I'm sure is not actually the end of your day. You're going to keep working, so thank you so much. We're grateful for all of your leadership globally. Bye. Thank you.
Thank you.